Hi, everyone. On today's podcast, we're going to talk about the updated evidence on diagnosing gestational diabetes. Hi, everyone. Welcome to today's episode of the Evidence-Based Birth Podcast. For this special episode all about gestational diabetes, I have a co-host today. My co-host name is Dr. Morgan Richardson Cayama, and I am so excited to talk with her today about the updated evidence on diagnosing gestational diabetes. You will be able to access all the information from this podcast, including scientific references, our updated full-length signature article, and a free 2-page handout by visiting ebbirth.com/diagnosinggdm. As a quick content note before we get started in today's episode, we will be talking about serious health complications for birthing people and babies, and we will also be mentioning sizeism and fat phobia. So Dr. Morgan has her PhD and master's in public health and is a member of the EBB Research Team. Morgan, I'm so happy to have you back with us.
Yeah, thanks so much for having me. I am really looking forward to diving into a lot of the research that we found on this topic. And I know there's a lot of interest and curiosity, and this impacts a lot of people. So I'm excited to join.
Yeah, we get lots of questions sent to us about gestational diabetes. And you've been with us since early 2024. You've been co-host and guest on a few podcast episodes now, including episode 334, which was a huge hit, all about the ARRIVE trial and elective induction at 39 weeks, and episode 343 on the top 10 evidence-based strategies for lowering the risk of having a cesarean. And for the past few months, you've been working with me to update the evidence-based birth signature article on diagnosing GDM. So the last update on this topic was back in 2019. And the research in this area has sort of exploded in the last 5 to 6 years. So for this update, we've added a lot of new content and research on this topic that we're excited to share. So gestational diabetes is a big topic, and diagnosing gestational diabetes specifically is surprisingly complex and quite controversial. So you're going to be learning more today as we make our way through this episode. We'll be focusing on defining gestational diabetes, explaining the potential health risks, and we'll be discussing the evidence on screening and diagnosis, including the evidence on alternatives to the traditional Glucola drink that is used to diagnose gestational diabetes. As a note, we do have a different signature article on inducing for gestational diabetes. If you're wondering about the evidence on my provider is recommending I schedule induction, we have a separate article on that. That's a whole nother topic in itself. And you can find that at ebbirth.com/inducinggdm. And we have plans to update that article, since it's kind of a companion to this one, sometime in the next year. All right, so Morgan, can you start off by giving us a little bit of a background on gestational diabetes?
Yeah, sure. So gestational diabetes mellitus or mellitus, it's often referred to as GDM, and this is high blood sugar that develops during pregnancy. And so without getting too much into the physiology of the process, which we absolutely go into a lot more detail about in the signature article, it is important to know that everyone experiences metabolic changes during pregnancy, and they experience some level of insulin resistance. This is pretty common and pretty normal across all pregnancies. And historically, this insulin resistance has helped prioritize the movement of sugar and nutrients to the fetus instead of the pregnant person, which helps, of course, promote healthy fetal growth and development. And it actually served us pretty well historically when we typically had less access to food, or when you think about periods of famine. But in pregnancies without GDM, the body's insulin response is still able to kind of overcome that resistance by producing more insulin. But in pregnancies with GDM, there can just be too much insulin resistance or too little of an insulin response, or even a combination of both. And this is what causes glucose or sugar to build up in that blood until it reaches abnormally high levels. And this is called hyperglycemia. And so, as we'll talk more about later, screening for GDM and diabetes in general involves measuring blood sugar levels. Gestational diabetes also is not the same thing as type 1 or type 2 diabetes, and diagnostic thresholds for gestational diabetes are actually lower for GDM than type 2, although management and treatment of GDM is pretty similar to type 2 diabetes. And pregnant people who develop GDM are also actually at higher risk for developing type 2 diabetes later in life. And so, how common is gestational diabetes, Rebecca? And what are some of the biggest risk factors that we need to be aware of?
Okay, so one of the reasons I think this is such a hot topic is because gestational diabetes is one of the most common health problems of pregnancy. And as we've hinted at already, there's a lot of debate over the best way to diagnose it and how to decide who has gestational diabetes. And actually, rates of GDM change depending on the test that's used and the cutoff criteria used to kind of define who has gestational diabetes. So most care providers around the world use something called the IAD-PSG criteria, which stands for International Association of Diabetes and Pregnancy Study Groups. So using these international criteria, researchers have looked at data from more than 40 countries, and they estimated a global rate of gestational diabetes of about 14%, and that was in the year 2022. So that's more than 1 in 10 pregnant people has gestational diabetes around the world. Now, in the United States and Canada, however, care providers follow different criteria for diagnosing gestational diabetes. They use something either called the Carpenter-Couston criteria or the National Diabetes Data Group criteria. And in 2020, the last year we kind of have national data for this, around 8% of pregnant people in the US needed treatment for gestational diabetes. However, it's been pretty much confirmed in the research that rates of GDM in the United States would double if we switch to those international criteria. Now, rates in general, regardless of which criteria you use, have been increasing around the world. And this might have to do with an increase in the number of people with risk factors for GDM. Now, before I go on, I do want to acknowledge the role that sizeism and fat phobia play in the way that people with bigger bodies are treated in healthcare in general and in maternity care. So healthcare providers sometimes show bias and can shame and stigmatize people with larger bodies. And even though most people with larger bodies will not develop gestational diabetes in pregnancy, they may be incorrectly labeled or treated as if they have it, even if later on they go on to have tests that show they do not have it. That all being said, one of the most commonly referred to risk factors for GDM is having a bigger body, which most studies define as a pre-pregnancy body mass index, or BMI, of 25 or above, or 23 or above for Asian Americans in the US. So BMI, as many of you know, is a flawed measurement, and this has been acknowledged, its flaws, by the American Medical Association, but it's still commonly used in research. And although rates of gestational diabetes are highest among those with higher BMIs, someone who is not plus size can still get GDM. In fact, about 25% of those diagnosed with GDM have a pre-pregnancy BMI below 25. You might also be at higher risk for GDM if you are older or advanced maternal age, typically defined as being 35 to 40 or older. If you have a history of gestational diabetes in a previous pregnancy, or if you have a history of insulin resistance, heart disease, or high blood pressure. If you've had a history of birth complications, like having a large for gestational age baby or having a preterm birth previously. If you have a close relative with diabetes, or if you belong to a racial or ethnic group at increased risk. So in the US, this would include people who are African American, Hispanic, or Latina, Alaskan Natives, Native Americans, South Asians, Native Hawaiian or Pacific Islanders, or those of Middle Eastern descent. So there are a few theories as to why some of these ethnic groups are at higher risk for gestational diabetes. There was a study led by Gitlin et al., and they noticed that differences in GDM prevalence across geographic regions might be due to differences in culture that leads to diet and activity levels, genetics, economic stability, and healthcare access. They also note that babies whose gestational parent experienced undernutrition during pregnancy might also be more likely to experience challenges with insulin deficiency and resistance later in life. increasing your likelihood for GDM and for diabetes as an adult. So it's a little bit complicated, but those are the risk factors. And like I said, it's one of the most common problems in pregnancy. So Morgan, we know a little bit more about GDM. Can you tell us why is screening recommended? Like, what is the purpose of doing the screening?
Yeah, absolutely. So GDM or gestational diabetes has been linked to higher rates of many poor outcomes. And just to name a few, that includes preeclampsia or high blood pressure during pregnancy, first time cesarean birth, preterm birth, having a large baby, newborn jaundice, newborn intensive care, and there are even some other ones that have been found in the research as well. So some studies have also found a higher risk, again, of type 2 diabetes in people who are diagnosed with gestational diabetes, as well as heart disease and stroke later in their life. And studies have also found that higher risk of type 2 diabetes and offspring for people who are diagnosed with gestational diabetes. So they might be at higher risk of developing diabetes as well later in their life. So one of the most famously cited studies that we talk about around gestational diabetes is the hyperglycemia and adverse pregnancy outcomes, or HAPO study. And this study looked at the link between prenatal blood sugar and the risk of those poor birth outcomes. So the study was published back in 2008, and it was a pretty big study that followed more than 23,000 pregnant people in 9 different countries. And these were people who were not previously diagnosed with diabetes. So everyone in this study was screened with a 75-gram oral glucose tolerance test, or OGTT, you might have heard it called, between 24 and 32 weeks of pregnancy. Now, we're going to talk more about those tests and OGTTs soon, but in this type of test, blood sugar levels are checked after fasting, and then again after 1 and 2 hours after drinking 75 grams of glucose. So the researchers then compared differences in health outcomes between 7 different categories of blood sugar levels across those 3 different time points for testing. So again, after fasting and after 1 or 2 hours. They found that the risk of many of these outcomes was highest among those with the highest blood sugar levels. So perhaps that's not really surprising. But one of the biggest findings from this study was that relationship between someone's blood sugar levels in pregnancy and the risk of poor outcomes was continuous, meaning there wasn't really a specific cutoff or a line that they could draw for risk or what was considered low risk and high risk. So instead, every small increase in blood sugar levels, even within blood sugar ranges that were considered normal, resulted in an increased risk for worse health outcomes. And findings from this HAPO study are what formed the basis of the gestational diabetes diagnostic cutoffs proposed by that IAD-PSG group that Rebecca just mentioned, which are used in many countries, again, around the world today.
So that's such an important point, Morgan, that you said about the HAPO study, because that finding that there wasn't a clear line where researchers can say this is normal blood sugar and this is abnormal. This is one reason why there's so much controversy over how to best test for and diagnose GDM. And so that kind of brings me into the best methods for screening and testing for this condition. So most professional organizations or clinical guidance recommends that people be screened between 24 and 28 weeks of pregnancy. So this is something you're typically doing in your second trimester. And the 2 most common screening tests are the 1-step method and the 2-step method. And both of them are going to use the oral glucose tolerance test, or OGTT, that you mentioned earlier. So the 1-step method became the most common method around the world after the HAPO study. However, this method is not used in the US or Canada typically. So with the 1-step method, you have to fast for at least 8 hours. You go in and have your blood drawn fasting to measure your fasting blood sugar level. You're then given a 75-gram glucose drink, and you have to consume that pretty quickly. And then your blood is drawn 1 and 2 hours after you've consumed the drink. So this is 3 blood draws. In contrast to that, the 2-step method is what we commonly use in the United States and Canada. So this approach involves an initial screening OGTT, and if you test positive, then you'll have a follow-up diagnostic OGTT. So in the first step, you would drink a 50-gram Glucola beverage, and you would have your blood drawn to measure your blood sugar 1 hour later. No fasting is required, and it's only 1 blood draw. Now, if your blood sugar levels are high, according to different cutoffs for the test, you might be scheduled then for a follow-up diagnostic test on a different day. And about 14 to 23% of people who drink that initial Glucola drink end up needing the second diagnostic test. The second step involves using either a 75 gram or 100 gram glucose drink that you drink fairly quickly. And so this is more glucose than you did in the first step. And it does require that you fast beforehand. So you come in fasting for the test, you have your blood sugar levels drawn fasting, and then you drink the 75 or 100 gram drink. And then your blood is drawn to measure blood sugar at 1, 2, and 3 hours after drinking the glucose. So this involves 4 blood draws with the second step. So neither of these methods is perfect. They both have their pros and cons. So Morgan, can you share with us some of the pros and cons of the 1-step and 2-step methods?
Yeah, absolutely. So with that 1-step method, as Rebecca mentioned, everyone does have to fast, or everyone who's getting screened has to fast or not eat for at least 8 hours before that test. And of course, that can be uncomfortable for anyone, but especially for those who are pregnant. And another drawback with this test is that you do have to attend a 2-hour lab appointment. And that can be difficult for some people in terms of getting to the lab and waiting around for blood draws. So you have really demands on transportation and time as well. Now, the 1-step method and criteria also result in more people being diagnosed with GDM, which can actually be both a good and a bad thing. So on the one hand, it's good because that means more people can be identified who might benefit from management and treatment. And these are people who could go on and make lifestyle and nutritional changes to try and reduce their risk of some of those poor outcomes. However, on the other hand, these also mean, like, being diagnosed with gestational diabetes might also mean higher personal and healthcare costs because you have to more closely monitor your blood sugar levels. You might have to have more medical appointments and meet with a nutritionist. And you might need to pay for testing supplies and medication, especially if you're somewhere where that wouldn't be covered by insurance. And you might have more out-of-pocket costs with that. People who are diagnosed with gestational diabetes might also experience more pressure by their healthcare providers to be induced. And that's definitely a consideration too. Now, with the 2-step method, you do not need to fast for that first step, as Rebecca said, and you only need to wait around for about 15 minutes to 1 hour before you need that blood draw. However, if you do end up needing to do that second step, like if your levels are high enough after the first step, then you need to go on and do the second diagnostic OGTT. You have to come back a different day after fasting overnight, and you do need to drink even more of that glucose, as Rebecca mentioned, so 75 grams or 100 grams, depending on where you are, and wait around for 3 hours to have your blood drawn. And again, you have those 4 different blood draws as part of that test. And so while the first screening step in the step 2 method is much less burdensome compared to that 1-step method, the second step is a lot more demanding and a lot more involved. And also, I should say that a potential con with both of these methods is that they involve drinking that glucose beverage, and Glucola, as you might have heard it called. And some people do experience side effects after they drink this. Again, it's a lot of glucose or sugar that you're ingesting in a short amount of time. And so some of these side effects that have been reported in research include bloating, abdominal pain, and nausea. And actually around 8 to 10% of people do experience vomiting, which can interfere with their ability to complete the test. And anxiety and worry around the test is also something that people report, or even anxiety and worry around having blood drawn, which is a personal issue for me as well, something that I wasn't looking forward to when I had my own GDM screening. And one study from 2022 found that 40% of patients who took an OGTT actually did not know why they were even taking the test. They didn't know what the screening was for, and about half had high levels of anxiety. And so I think this really shows that we can also be doing a lot better about educating people not only around gestational diabetes, but even why we screen for it, how we screen for it, and what the screening and these tests involve. And so as you can see, both methods, again, do have their pros and cons, but we also have some newer evidence comparing actual health outcomes and risks and benefits between these methods. So Rebecca, what does this new evidence suggest?
Yeah, so in our previous version of the signature article, we talked about a Cochrane review that was published in 2017 that attempted to compare the benefits and risks of both methods. However, at that time, there were only a few small studies, and the researchers concluded we needed more studies and larger randomized trials on this topic. So now in 2025, we have results from some of these large trials that the researchers were calling for to be done. And overall, I find this really interesting because the global community was really excited about the one-step method and thought, yes, we're going to diagnose more people, but we're going to help so many more people and outcomes will be better. In general, the research that has come out in the last 5 to 6 years has shown that the one-step method increases the number of people who are diagnosed and treated for GDM, but doesn't actually improve health outcomes at the population level. So, for example, there was one large trial published in 2021 by Hillier et al. This was done in 2 hospital systems in Hawaii and the Pacific Northwest in the United States. So they included everyone who gave birth at these facilities between 2014 and 2018, and they were able to include everyone because it was standard care. So they didn't have to get informed consent from the participants. They just randomly assigned them to get one of the 2 types of standard care, the one-step or the two-step. And they ended up with nearly 24,000 participants, and 94% of them completed a gestational diabetes screening, either the one-step or the two-step method. And as you would expect, rates of GDM were much higher in the one-step group, about a 17% rate of GDM compared to 9% in the two-step group. And they looked at many different maternal and infant health outcomes. They looked at rates of large babies, gestational high blood pressure, inductions, cesareans, preterm births, stillbirths, NICU admissions, and much more. And they found no differences between the 2 groups in any of these outcomes, except there was a slightly higher rate of low blood sugar in newborns in the one-step group that was less than 2% higher. So it was statistically different, but it wasn't a huge difference. And then in 2024, Gomez et al. Published a meta-analysis that combined studies, and they had 15 times the number of participants from that 2017 Cochrane reviews. This was huge compared to the research we had in 2017. And they combined data from 7 different randomized trials, including the trial I just discussed. They found, as we would expect, the one-step method led to more people being diagnosed with GDM, but they did not find higher rates of medication for GDM. They did find that the one-step method resulted in higher rates of NICU admission in newborn low blood sugar, but slightly lower cesarean rates. And the authors concluded that we need more research on long-term outcomes, like whether or not the one-step or two-step method has any impact on eventual type 2 diabetes diagnoses in the gestational parents and their children. So we go into a lot more detail about these studies and other studies that have come out about diagnosing GDM. So go to the signature article, ebbirth.com/diagnosing GDM, if you want to learn even more about this new area of research. Another area of research that we looked at is screening early in pregnancy for gestational diabetes. So Morgan, can you highlight for us what we found when we were looking into this research?
Yeah, so this was a big kind of deep dive that I took when I was looking into the literature, because there has been so much new research on this topic. And again, we go a lot more depth and dive into a lot more detail in the signature article. But there have been several studies published in the last few years looking at the effectiveness of early GDM screening and treatment. So just as a reminder, most professional organizations recommend screening in early pregnancy for pre-existing type 2 diabetes, not GDM. And type 2 screening is often targeted only in people with those risk factors that Rebecca described earlier. You can learn more about that early screening for type 2 diabetes in the article. But early screening for GDM is screening done well before the usual time frame of 24 to 28 weeks, or that standard of care that we currently practice. And early screening usually in the research even happens before 20 weeks. However, this early GDM screening has been complicated by a lack of clear guidelines or cutoff values for what's considered gestational diabetes, especially in comparison to that pre-existing type 2 diabetes, and a lack of really effective screening methods in early pregnancy. And we'll talk a little bit more about why that is too, and why screening is just more complicated in pregnancy in general. But in these early GDM screening studies, researchers have been exploring different diagnostic thresholds and cutoffs. They've also been exploring different methods like hemoglobin A1C oral glucose tolerance testing and fasting plasma glucose or fasting blood sugar levels, for example. So one study found that early hemoglobin A1C testing before 16 to 20 weeks of pregnancy could be really beneficial in helping to rule in and rule out people with gestational diabetes, and go on to help some people avoid having to even ever need a second trimester oral glucose tolerance test. So, for example, people with really high hemoglobin A1C levels early in pregnancy could be ruled in as pretty much automatically having gestational diabetes or receive that diagnosis early and go on and start receiving treatment early. People with really low values, on the other hand, could pretty much be ruled out as not having gestational diabetes. But anyone with values in between really low and really high values would still need to go on and do that second trimester oral glucose tolerance test. So far, this research points to some benefits of early screening and treatment, and some researchers who have been doing research in this field believe that we now have enough evidence to recommend it. So, for example, one well-known randomized control trial, it's called the Treatment of Booking Gestational Diabetes Mellitus, or TOBOGAM trial, found that early treatment of GDM before 20 weeks of pregnancy lowered the risk of a poor perinatal composite outcome, or a combined outcome. And this is where the researchers looked at things like preterm birth, having a big baby, newborn respiratory distress, stillbirth or newborn death, and a few other poor outcomes for babies. And what they found was that the rate of this outcome was lower among people in the early treatment group at around 25%, compared to 31% of people in the control group who did not have early GDM treatment. So they just had the usual standard of care, their screening 24 to 28 weeks, and then received care if needed. However, one of the main reasons for this difference was because the rate of newborn respiratory distress was lower in that early treatment group at around 10% versus 17% in that control or standard of care group. So this was an unexpected finding by the researchers, and they're not really sure why they saw this, but these researchers still believe that there is enough evidence that as evidence continues to grow on early screening and treatment, that we can begin to recommend early GDM screening and treatment. But this is only one study. There have been other studies, granted, they're typically smaller, the TOBOGAM trial, and these studies haven't found any differences in outcomes between people with early or standard treatment. Some professional organizations, including the American College of Obstetricians and Gynecologists, or ACOG here in the US, still do not currently recommend early GDM screening, just because they don't feel like there's yet sufficient evidence on the benefits and harms of diagnosis and treatment before 24 weeks. But this is a rapidly growing area of research. It seems like new studies are published, every few months on this topic. So it's going to be interesting to see how this evolves. And we expect that these professional organizations will continue to monitor that evidence, and they may even update those guidelines in the future. So that's definitely something we want to stay tuned about.
Yeah, we'll have to keep our eyes open for new recommendations on the early screening, because I think the research is kind of shifting that way. Can we identify people before that 24 to 28 week time point? And I also like that option of perhaps having a hemoglobin A1C, which can be done point of care, by the way. It doesn't have to be a blood draw. It can be done with finger stick point of care device to see if you can have that earlier in pregnancy. And if the results are low enough, you could skip the Glucola drink later in pregnancy. That would be nice. Yeah. So we've talked a lot about the oral glucose tolerance test and the infamous Glucola drink that I was just mentioning. And this is still considered the gold standard when you're screening or diagnosing gestational diabetes. However, we get many questions from families about whether they have to drink the Glucola or if there are any other ways that they can be tested for GDM. And the answer is yes, there are alternative options. And one of the newer options that's come out since we last updated this article, this is for people who are okay with drinking a glucose drink, but they're concerned about dyes or artificial ingredients in the standard Glucola beverages. There are now options available without these ingredients. And one that is commonly mentioned to us here at EBB is the fresh test. You can learn more by visiting their company website, but on their website, they state that they are labeled as a diagnostic class 2 medical device by the FDA here in the United States. And so they are considered equivalent to other glucose beverages. So you can order those directly from their website, or if you want faster shipping, you can order them from Amazon, although the price does go up quite a bit if you order the fast shipping version. We paid for ourselves. We don't receive any funding or sponsorships, and we don't get free products here at EBB, but we ourselves went online and ordered a couple of fresh tests to just do taste testing out of curiosity for me and Morgan's sake. And I ordered them both to be sent to different locations in Kentucky, and one reached Morgan's place in about a week using the company standard shipping, and mine has still not arrived. So if you are interested in this option, make sure you get it well in advance, unless your provider stocks it themselves. It's also worth checking with your provider to see if, they are accepting of this drink, but I think it's still a pretty good equivalent to the Glucola drink. And we also came across another recent study published out of China that looked at the impact of temperature in adding green tea or soda water to the standard glucose drink. So they looked at 8 different combinations. So they had the glucose solution in room temperature, or hot, or cold. They did glucose at room temperature, hot or cold, but with a green tea bag added to the drink. And they also looked at glucose in room temperature, liquid, or cold water mixed with soda water or sparkling water. And the researchers measured people's perception of taste, side effects, the blood sugar levels, and the rates of being diagnosed with gestational diabetes. And they found that people preferred the taste of the cold solutions or those that included the green tea. And these led to slightly less nausea, but no difference in rates of vomiting. There was also no difference in rates of GDM diagnoses, which is a good thing and means that these, changing the temperature or adding green tea does not adversely affect the test. However, the glucose in cold soda water or sparkling water did impact participants' 1 hour blood sugar levels, so it was ultimately not recommended by the researchers. But it's just something good to know, that making sure that the drink is really cold, or you could add a green tea bag to it to improve the taste. Those are some options. There are a few other alternative methods that people often ask us about, like eating candy or food before testing, home blood sugar monitoring, doing a random fasting glucose test, or blood sugar testing, and hemoglobin A1C testing. So Morgan, what's the evidence on these methods?
Yeah, so again, we don't really have time to dive into all of the research and every single study across all of these different alternative methods, but we do present, again, all of that information in a lot more detail in the article, and I am very happy to give the cliff notes. So first, it is important to note that these methods typically do not perform quite as well as the oral glucose tolerance test, especially when it does come to identifying gestational diabetes later in pregnancy. And so, for example, fasting plasma glucose or blood sugar, it does work really well in diagnosing diabetes in non-pregnant people. But one of the drawbacks with this method is that it doesn't test your body's ability to handle glucose after eating. So meaning that it doesn't challenge your body's ability to handle that extra load of glucose, which is important for identifying gestational diabetes during pregnancy. So seeing, after you eat a meal or after you have that extra blood sugar, is your body able to overcome that extra insulin resistance, for example? Now, hemoglobin A1C testing is another common alternative method that we hear about. However, it unfortunately also has its issues, especially later in pregnancy. So this is because hemoglobin A1C levels fluctuate during pregnancy, and these levels can also be impacted by iron deficiency anemia. Now, iron deficiency overall, it's a pretty common issue during pregnancy. And iron deficiency anemia specifically impacts around 12% of pregnancies here in North America. So that's another reason why this one is just a little bit harder, a little bit less accurate at diagnosing gestational diabetes. Now, one thing with the hemoglobin A1C testing, as I talked about earlier, is that it does, again, show promise, especially in early pregnancy, for being able to rule in and rule out people with gestational diabetes. But again, because those levels fluctuate over pregnancy and because of how they're impacted by anemia, it just kind of loses its power, or it just isn't as effective later in pregnancy. So that is one drawback with this method. Now, candy and food alternatives, you mentioned, Rebecca, these are pretty popular, and I think we get a lot of questions about these as well as EBB. And actually, Rebecca, I think that you have some personal experience with this method. So can you tell us about that, and then maybe more about what the research says with that type of approach?
Yeah, so I was one of the 10% who vomits and gets really sick after drinking the oral glucose challenge test. So with my first pregnancy, that was a very difficult experience. So the second time around, I still wanted to know if I had gestational diabetes because I thought it was important. But at the time, I didn't really know a lot of the research. And so I was just trying to figure out, okay, if I just challenge my body and what is the sweetest thing I could eat and then go in for the test. And I don't recommend this, but I didn't tell them that I did this. I just said I drank the glucose beverage. And, there wasn't in a practice where I felt like I could have transparent communication about this, but I did want to challenge myself. And so I found the sweetest thing I could eat, which was a slice of carrot cake with cream cheese frosting, and it had a ton of sugar in it. And I normally don't eat that much sweets, so I had a large slice. And the funny thing is that I still felt sick afterwards, which I think many of us can identify. When you have a large load of glucose, like if you're not used to it, your body reacts to it, right? That's the side effect we're feeling when we do the glucose challenge. And I only realized later that this is just not equivalent to the glucose test. And I did really well. My blood sugar recovered really quickly. It was at a normal level after, when I got my blood drawn, which I thought was a promising sign since I just physically couldn't drink the Glucola beverage. But what I didn't realize at the time is that that is not going to be an equivalent test for those cutoffs that they use, because there is, fat, fiber, other complex carbohydrates in that cake that then changes how your body digests and metabolizes the sugar in it. So that's one reason that food or meals are not typically recommended, because then the cutoff values aren't going to work the same. And unfortunately, carrot cake has not been included in any studies that we've come across. However, researchers have studied the effectiveness of GDM screening using some candies that have more simple sugars and don't have like all that added fat and fiber that I had in my carrot cake. So the tests that have been done include candy bars, candy twists, kind of like Twizzlers, and jelly beans. And the research studies that we've found have shown that people often prefer eating candy over drinking a Glucola beverage, and they typically have fewer side effects. However, the research on this, there's just a few older studies on this topic, and most of them are pretty small studies. And they've also shown mixed effectiveness in identifying people with GDM. And as I mentioned earlier, one drawback of any food-based GDM screening is that there are different kinds of sugars, and they don't all have the same effect on your blood glucose levels. So different candies can have fats or proteins or added ingredients that aren't present in the glucose drinks that can alter your blood sugar results. So this means someone who has true gestational diabetes might not get a positive result on their GDM screening test if they replace the Glucola drink with some kind of candy. This could result in a missed diagnosis. Also, candy alternatives have only been examined as, potential alternatives to the 50-gram two-step glucose screening test, not for a diagnostic test with the 75 grams or 100 grams. So in all of the candy studies, people with positive results still had to follow up with an OGTT to determine whether or not they meet diagnostic criteria for GDM. So another popular alternative that does not involve consuming candy is for someone to monitor their blood sugar at home, to get a blood sugar monitoring device to do finger pricks and track them and then discuss their results with their care provider. So one obvious benefit of this home monitoring approach is that you don't have to drink the glucose beverage, and you can do it in the comfort of your own home. But it does require frequent finger sticks, and you need access to a device and testing strips. And you have to remember to perform the test throughout the day or for multiple days. Another downside of this method is there's no clear standard for diagnosing GDM with this method. And it's also really important that pregnant people follow their normal diet if they're using this method. So the provider can then provide guidance on whether testing can be stopped, needs to be continued, or if GDM management or treatment is needed. So those are the different options, alternative options for screening and diagnosis. And as we mentioned at the beginning of this podcast, there's still no single agreed upon approach. So knowing that, can you highlight for us what some of the different health organizations are recommending so we can kind of see the differences from country to country.
Yeah, of course. And there are a few, as you mentioned, Rebecca, there tends to be disagreement on that one or two step approach. But yeah, one reason that this topic is so confusing, and I think we get so many questions about it, is because the guidelines do vary depending on which country and which professional organization you refer to or whose recommendations that you're looking at. So here in the United States, the American College of Obstetricians and Gynecologists, or ACOG, does recommend that two-step approach with an oral glucose tolerance test. In step one, again, they recommend all pregnant people be screened for gestational diabetes using the 50-gram 1-hour OGTT between 24 to 28 weeks of pregnancy. People who have those high blood sugar levels, depending on the criteria used by the provider or the hospital, then go on to do that step 2, which again is that 100-gram 3-hour OGTT. So again, ACOG does not currently recommend early screening for GDM. They do recommend early screening for pregestational type 2 diabetes in people with risk factors. So in Canada, the Society of Obstetricians and Gynecologists, they also recommend a universal two-step approach similar to ACOG, where everyone who is pregnant completes a 50-gram 1-hour OGTT, again between 24 and 28 weeks. Now, their step 2 diagnostic test is a 75-gram 2-hour OGTT, so that's a little bit of a variation from us here in the US and with ACOG. But they also state that the one-step approach is acceptable. It's not the preferred, but it's acceptable. And like ACOG, they currently do not recommend early GDM screening, but do recommend screening for type 2 diabetes early in pregnancy for people with risk factors. Now, in the UK, the National Institute of Health and Care Excellence, or NICE, they recommend a targeted approach, meaning only people with risk factors are even screened for GDM. So they recommend using a one-step approach with a 75-gram 2-hour OGTT between 24 and 28 weeks of pregnancy. However, if you've been previously diagnosed with GDM, they recommend either self-monitoring or the one-step 75-gram OGTT at the first prenatal appointment, and then a second test between 24 to 28 weeks if needed. If their levels are normal, if your levels are normal during that first step, you would still get a second screening at 24 to 28 weeks just to double check. So hopefully that provides a little bit of clarity for folks. We do have a convenient table in the signature article that lays out all of these different recommendations across some of the different professional organizations around the world. And I'm a visual person, so I think that is a lot more helpful for me to kind of see how these different organizations, and even some that I didn't mention here, follow gestational diabetes screening and diagnostic recommendations. And so aside from these, there are also people who are just not interested in being screened for gestational diabetes. And so, Rebecca, what if I want to decline the gestational diabetes test? And what are the risks? What are some risks that I might face if I don't want to be screened at all?
Yeah, so first, the disclaimer for me is that having a test for GDM is considered evidence-based care because there are substantial risks to your health and your baby's health if you have abnormally high blood sugar levels and they're not identified and treated during pregnancy. But one of the interesting updates to this version of the signature article is we did find a study published earlier this year in 2025 by Nethery et al. They looked at health outcomes among pregnant people who chose not to screen for GDM, which they refer to as screening non-adherence. I think this is fascinating because we've never had a study on this before. So this study was carried out in British Columbia, Canada, and it looked at all births where the birthing person gave birth to only one baby between 2006 and 2019 and whose care was led by a midwife. They did this because declining to be screened for GDM is more common in pregnancies with midwifery-led care. It's more likely to be because the pregnant person chose to decline the test rather than an issue with access to screening. So it's not because they have less access to care or prenatal care in general, but because it was their choice. And the researchers looked at a range of health outcomes, like was your baby large for gestational age or small for gestational age? Did your baby have low APGAR scores at birth? Were there higher rates of preterm birth, NICU admission, cesarean, perineal tears, and stillbirth? And in their analysis, the researchers controlled for other factors that can impact these health outcomes. So they took into account things like age, smoking, BMI, and other risk factors for poor health outcomes. So they were able to include about 83,500 pregnancies, and then they categorized the pregnancies based on screening status, including those who completed standard OGTT screening between 24 to 28 weeks, those who did non-standard screenings like getting the hemoglobin A1C or doing random blood tests to check for blood sugar, and those who did not screen or do any testing at all. So they had about 18,000 participants who did not screen at all. And when they compared them to those who completed routine screening and had normal blood sugar levels, which was around 58,000 people, they found that those who did not screen had a lower risk of large for gestational age babies and cesarean, but they had a higher risk of stillbirth and a higher risk of small for gestational age babies. They didn't see any differences in any of the other outcomes between these two groups, again, comparing those who declined screening and those who did the screening but had normal blood sugar levels. The researchers also wanted to see if there were differences in outcomes between people with and without pre-pregnancy risk factors for GDM in the non-testing group, so targeting like a higher risk group of people who declined to be tested for GDM. And they found, unfortunately, an even higher risk of stillbirth in those with risk factors who declined to be tested for GDM. Their risk of stillbirth was 2.5 times higher. However, the researchers noted there is a possibility that people who declined GDM screening might have also declined other interventions like screenings for fetal anomalies, or they could have declined other health treatments that could have increased their risk for stillbirth. And the researchers noted that, quote, our findings strongly support screening for those with pre-pregnancy GDM risk factors, end quote. Here at EBB, we do want to remind you that it is a human right to decline medical treatment unless you are found formally to be incapable of making medical decisions. And in the United States, at least, ACOG has affirmed that mothers with GDM have the right to individualized care and the right to refuse care. So we have another interesting question. I thought it would be interesting to kind of end with, and it's come up a few times now. It keeps getting sent to us by email and on Instagram, and we addressed it in our signature article update. And this question revolves around the role that sperm plays in the formation of a pregnancy and the risk of GDM. So Morgan, what did you find when you looked into this?
Yes, I love this question because I have also had friends that have asked me this or have sent me research on this, and it's really interesting. And the short answer is, unfortunately, we cannot say for sure whether the sperm used to fertilize the egg causes GDM. That causal relationship, again, we can't 100% say that that is the case. However, the suspected link between sperm and GDM has to do with the sperm's role in the development of the placenta and the placenta's role in the risk for GDM. And I just want to say, too, there are many genetic and environmental factors that impact someone's risk of developing gestational diabetes. Hormones do appear to play a large part in the development of the placenta, and the hormones released by the placenta are what contributes to that insulin resistance. So we know hormones are one part of this equation as well. And researchers have been exploring the ways that epigenetic factors from the male biological parent or from the sperm donor in the case of an assisted sperm donor pregnancy influence the health of the baby and the development of the placenta. And so epigenetics has to do with behaviors and factors in the environment that cause changes that affect the expression of genes. And these can be impacted by things like the person's health, or your age, for example, and even environmental exposures like substance use, or if you've been exposed to food insecurity, or even exposure to trauma. And studies have shown that these factors specifically can impact epigenetic changes in the DNA in the sperm, and that the sperm, again, plays a role in the development of the placenta. So this is all kind of related and associated, all of these factors, but we really need more research to fully understand the ways that the sperm and the placenta and GDM are connected. And we do link to some of these recent research articles and resources where you can learn more about these connections in the signature article. So it'll be interesting, too, to kind of follow this research and see how it progresses and what people say ends up kind of being that connection and that big picture between sperm and the risk of GDM.
That's such an interesting question. It just raises so many questions in my mind about the risk for preeclampsia, because that's also related to the placenta, or gestational hypertension. And then, what about preconception health of the male biological parent, and what role does that play? So I think it's going to be an interesting area to watch the research evolve. And maybe next time we update this article, we'll know even more. So before we wrap up, I'd love to know, Morgan, what was something that you learned or surprised you while you were researching this topic? So you mentioned to me, this was a new area of research for you to dive into. We have spent like half a year reading the research on this together. And, what's one of your surprise takeaways?
Yeah, well, in addition to the sperm's role, which again, I'm very fascinated by, I really wasn't all of that familiar with the range of alternative methods. This was not really something that I had explored before. I had just sort of accepted my fate of having to drink the glucose drink, even though knowing from, friends that it wasn't the most enjoyable thing during pregnancy. But for me, like I had mentioned earlier, I was a lot more concerned and had a lot more anxiety around the blood draws associated with the test and just blood draws in general throughout pregnancy. That was what kind of gave me the most sort of fear. But yeah, just knowing that there's all of these alternative methods, especially if you are someone who experiences a lot of nausea or vomiting with the test, or if that's one of your fears, I think that there's a lot of different promising methods that you can talk about with your provider and see what might be right for you. So that was something that was cool for me to learn about.
Yeah, and I'm really interested to see if the early testing using the hemoglobin A1C finger prick, evolves into something that becomes more available. I know in the research we reviewed, they talked about its usefulness in parts of the world where you don't have access to laboratories and you can't have blood draws, and how that might be really helpful in identifying people early who are at high risk for GDM. And then for me personally, I was most surprised by all of this new research really showing no clear benefits of the one-step method over the two-step method. Like for a long time, it felt like in the US, we were kind of behind the times using the two-step method. And I think the reason we still did is the organizations here wanted to be conservative. They're like, this is going to double the number of people diagnosed with GDM. Our healthcare system can't really support that. And we don't know if there's actual benefits to doing that. And it's interesting to see that now there's research kind of supporting that approach is okay. And I'm curious to see how that research will evolve over the next 5 years. So that was kind of my big takeaway. So as we wrap up, what is the bottom line on diagnosing GDM? So GDM is diabetes that begins during pregnancy, but we also have to be aware that some people enter pregnancy with undiagnosed pre-existing type 2 diabetes. And for this reason, you might see providers offering diabetes screening early in pregnancy if you have risk factors. Most organizations around the world still agree that GDM screening should take place between 24 to 28 weeks of pregnancy, but there is still disagreement on the best way to do this. So in the US and Canada, the two-step method is commonly used. Most other countries around the world prefer the one-step method. Both of these methods involve the use of oral glucose tolerance tests, often with the Glucola drink. There are alternatives to drinking the standard glucose solution. So if you'd rather not drink the standard glucose beverage, or you can't due to vomiting or other side effects, you can talk about alternative methods with your provider. However, we don't have sufficient evidence to state which alternative best or how accurate these alternatives may be. We do, though, have strong evidence that treating GDM improves birth outcomes for both birthing people and their babies, and screening for GDM is considered evidence-based care. It's also important that we shift how we talk and think about being diagnosed with gestational diabetes. Most of the time, when you hear someone describe their results, they'll say, I failed the GDM test, or I had a failed screening. This is really stressful and can require lifestyle changes or management and treatment that can be demanding or costly. But I really would prefer that we stop using the word fail and instead talk about, testing positive for GDM, or the screening test was positive and I have to go on to do the diagnostic test. So just because if you do the two-step method, just because that first step was positive doesn't mean you are going to have a diagnosis of GDM. And the benefits of positive tests are that you can uncover potential health problems before they progress and adversely affect your birth outcomes and the health of you and your baby. So a positive diagnosis can be a real opportunity to make some small shifts in your lifestyle or large shifts if needed that can positively impact the future health of both you and your child. So we covered a lot of information today on diagnosing gestational diabetes, and there's even more info in this article that we didn't have time to cover on the podcast. You can find everything in the newly updated signature article, Evidence on Diagnosing Gestational Diabetes, on our website at ebbirth.com/diagnosinggdm, along with an updated 2-page handout in both English and Spanish. We'll also link in the show notes to our article on inducing labor for gestational diabetes, a related article all about big babies. And then one of our favorite resources for gestational diabetes is a book called Real Food for Gestational Diabetes by Lily Nichols, who's a registered dietitian, nutritionist, and certified diabetes educator. Her books, especially the Real Food for Gestational Diabetes one for this topic, it's evidence-based and includes citations to research articles, and it can be really helpful if you have that positive test. So thanks again for joining us, everyone, today on this really important episode. I hope you found it helpful, and we look forward to talking with you again soon. Bye, everyone.